Okay, this is going to be the third and final part of the cardiovascular. I know this is a long one, but like I mentioned, I'm hoping that you pulled out your drug cards or you're able to print the PowerPoint slides so that you can take notes as we're going along. Most important of all, whenever I talk about a group of drugs like beta blockers, ACE inhibitors, the sartans, the ARB drugs, when I talk about Coumadin, heparin, I'm pointing out the things that are most essential. So when you guys read the chapter, and the chapter is close to 100 pages long and it's just packed with information, or whenever you're looking up a drug and there's just pages and pages and pages, you can't figure out what's the indication, what's the use, what's the main use, or what is the most important side effect. There's just so many listed, it just seems endless. I'm providing that to you. So as you go through these slides, on the reason I've made this into a videotaped recording of the PowerPoint, you have the PowerPoint to go through at your own pace. You have the PDF, you can print it out. And then on the video, you can pause, you can rewind, you can replay. But this is your opportunity. I've gone through, this is after I've been a pharmacist 30 years. I've been working with pharmacy technicians specifically and becoming certified technicians for 7 years. And keep in mind, guys, I've taken the PTCE test multiple times, over 11 times. So I know exactly, I know what's on the test. I've seen what's on the test. And then I study the materials that come out in the lesson plans, the blueprint, the map of the PTCE exam. And the thing is, there are over 3,000 drugs used in pharmacy practice. Pharmacology is 40% of the PTCE. That can seem overwhelming initially till you realize that they're going to focus on the top 200 drugs. In the top 200 drugs, what information is it reasonable to expect an average pharmacy technician to know? Well, that's what I'm pointing out here. Or for example, when I talk about Coumadin or warfarin, warfarin's a medication anybody that's had a heart attack or stroke will be taking, and they'll take it for the rest of their life. It's a medication that was originally used as rat poison. It's poisonous. If somebody takes too high of a dose and they just bump into a wall or fall, they smash blood vessels, they won't coagulate, they will bleed to death internally. So a simple error or a drug interaction that's overlooked, or even a food interaction, if the patient doesn't know, can result in death. That's not the case with very, very many medications. But because it is with Coumadin, as a technician, you're expected to know this. You're expected to know Coumadin comes in multiple strengths. You're expected to know the drug interactions with Coumadin. At least most important is aspirin. You're expected to know that green leafy vegetables that are rich in potassium, they will prevent Coumadin from working as effectively. So on the other end of the spectrum, as opposed to having too much Coumadin in your bloodstream, if a person's taking Coumadin and eats too many green leafy vegetables and they have vitamin K, that vitamin K prevents the Coumadin from working. So then they're just predisposed to a clot, which is the whole reason they're taking the Coumadin. This is something a technician needs to know and know by memory. Anything that you have to look up, Google it real quick, well, that's something anybody could Google. What they're looking for as a technician, they're looking for somebody who we've got a pretty good guide of the medications and what you've got to know, what you have to know. You have plenty of time to memorize these. You're tested over these over and over. You're tested in the drug test. You're tested in the material over the drug system or the body system. So anyhow, as we go through these, I created this PowerPoint. It took quite a long time to make this PowerPoint, but I did it specifically to make sure and focus and include the information that you need to know. I've even gone to trouble to hopefully didn't oversimplify, but to make terminology or processes or how something works as simple to understand as possible, and particularly so that it'll help you in understanding it, learning it, having something to study and memorize. So what's a thrombus? A thrombus is when you have a blood clot. And in particular, it's a blood clot that's transported in the blood. How do you get a blood clot? Well, it starts with platelets. When platelets stick together, when the platelets are typically, they're slippery. And they're sticky. We have one drug called Trentol, which is pentoxypholine, And you don't see that dispensed as much, but when it first came out, it was revolutionary because it made platelets less sticky. It made them slippery. And by doing so, it helps prevent blood clots. But we've come a long way. That was about 25 years, 30 years ago. Anyhow, with a blood clot, you have platelets. They're sticky. They stick together. Once they stick together, it's kind of like a snowball rolling down a hill. And then those platelets, they develop into a clot. As that clot gets bigger and bigger, a couple of things can happen. One, it can break off into several clots, each of which is going to become a bigger clot that can break apart. Or when a clot gets big enough, it will plug a vessel capillary or artery. That's whenever it becomes life-threatening. Whenever it's pretty much think of if you have plumbing in a house where you've got water going to the kitchen, to the restroom. If you cut off a pipe to one of those areas, it's no longer functioning. Well, in the heart, you've got to have blood circulation because your organs need oxygen for cell tissue to develop and thrive. You've got to have nutrients to provide to build new cell tissue, and then you have to have a way of eliminating the waste byproducts as cells die or whatever remains from the breakdown of metabolic processes. So a pulmonary, what is the word pulmonary? Pulmonary means lung. Pulmonary embolisms, when you have a piece of blood clot, it breaks off and travels to the lung and it blocks the pulmonary artery. Why is this important? The lung, this is how oxygen is getting to the heart. It goes to the heart, then gets circulated throughout the body. You block this off, you're cutting off oxygen supply throughout the body. It's this lack of oxygen supply that causes muscle tissue death and organ death or organ damage. A deep vein thrombosis, that's just what it says. It's a thrombus or thrombi. So it's usually one thrombus that just breaks apart into tiny thrombi, and like a snowball going downhill, they get bigger and bigger. They form in areas of low velocity blood flow. What does that mean? That just means areas of your body where the blood flow is not as dynamic or not as forceful or powerful. Where's this? Well, because of gravity, if you're just standing upright, your fingers are pointed down to the ground. Well, gravity, for the blood to flow up, it takes more energy, it takes more force, more dynamic energy. Think of your legs. Your legs are furthest from your heart. Your feet are the farthest. When you're standing upright, they're fighting gravity. So as you get further and further away from the center of your body's core or the heart, the blood velocity, it becomes less and less. And these are areas where if you do have a thrombus, they're going to make that flow, it's going to compromise it even worse. So if you have a thrombus and you have a high flow of blood, there's a likelihood that it's just going to break the thrombus apart into just so many tiny thrombi that they just end up dissolving or disintegrating. But when you have low blood flow, the thrombi, they're just going to tend to get bigger and bigger and then ultimately completely close off circulation. Deep vein thrombosis, this is most important after somebody's had surgery. After surgery, just as your body's recovering, you're going to have tiny microscopic particles of thrombi that ordinarily, if they're using heparin and they're using medications to prevent thrombi formulation, then you won't have a problem. But if they don't have it set right or don't do it in time, you're going to end up with thrombi, and this is how people end up having to have arms, feet amputated. What's an anticoagulant? Well, coagulation, that's when your blood, whenever you get a cut, you cut yourself, and it takes just a few minutes before it becomes solid and eventually forms a scab and then heals. But a coagulant, an anticoagulant helps prevent the thickening of your blood. It helps prevent the blood from forming thrombuses. And then what's an antiplatelet? Well, the thrombus all starts with a platelet. The platelet's the smallest, and like I said, they're sticky. When platelets, they stick together, they just form a tiny little, a bit of a molecule that becomes bigger, larger, becomes a thrombus. And then, like I said, the thrombus gets bigger, it can break apart and become multiple thrombi, or it can just get so big that it lodges and disrupts it just completely shuts off the circulation in a blood vessel, vein, or artery. So these, most important thing out of all this, because this is a bunch of big words and you're not expected to remember these, not as a technician. If you worked in a hospital pharmacy, especially if you worked in a critical care area like an ER, or if you worked in one of the surgical sections, you'd be very familiar because you'd be constantly stocking the cart. Most of these come in pre-filled syringes, but we have Angiomax, Pradaxa. Pradaxa, this one, you might even see it advertised on television. It's dabigatran, and it was one of the first alternatives to Coumadin, but it's still not a great alternative. It has the same similar interactions with aspirin. For example, there was a practice PTC question that a patient's on dabigatran, and he's complaining of some mild aches and pain. Which analgesic would the pharmacist recommend? The options were aspirin, ibuprofen, naproxen, and Tylenol. Well, if you think hard, you remember aspirin, naproxen, ibuprofen, those are all non-steroidal anti-inflammatory drugs. They can upset the digestive system, they can cause bleeding, they can cause ulcers. Tylenol does not. So Tylenol is the option. So even if you couldn't remember what dabigatran is, just by virtue of looking at the multiple choice options, 3 of them are very similar, and then Tylenol is not. And so that would be an indication that's your answer. So anyhow, there's a direct thrombin inhibitor. What this means is these are drugs, somebody, when they have surgery, they're placed on these drugs immediately to prevent thrombin formation. Then there's a factor X, a factor 10A. Factor 10A, there's just a series of events that occur towards formulation and coagulation. So we have Xarelto, that's when it's advertised on TV, Arixtra, Savasa, and Clequas. They're used to prevent and treat deep vein thrombosis and pulmonary embolism. And primarily prevention, this is after surgery, after somebody's had a car accident and they're brought to the hospital, any kind of situation where somebody's predisposed to any kind of clot formation. Then treatment. One of the most common examples of thrombus formation is in females that take birth control and smoke. Also change in the air pressure gravity. If somebody flies in a plane and you're sitting upright, so you're not moving around, there's minimal circulation, that predisposes you to having a development of a thrombus. Birth control, hormones, female hormones, they increase the potential to form a thrombus. And then smoking, and what happens in smoking, the smoking or vaping, the irritation causes a disruption of cellular membrane in the lung bronchial tissue. That's all it takes, just to have a tiny microscopic speck that gets into the bloodstream, platelets stick to it, and then it forms into a thrombus. So it's very common if you work in a hospital, especially the ER, if a young woman comes into the hospital and says, I'm having pain, I can even point to where it is, I don't know why I have it, Tylenol is not helping, it's right here, just right up above my knee on my thigh. The doctors know immediately, before they even do diagnostic testing, they're going to put them on a medication, one of these drugs, to try to dissolve it as quickly as possible, because it's all a matter of time with thrombus formation. So DVT stands for deep vein thrombosis. Remember, deep vein, these are the areas where blood circulation is not as powerful or strong. So it's the feet, the lower legs. And then pulmonary is lung. Heparin. What is heparin? Heparin is an anticoagulant. Now, the thing about heparin is it's only available in an injectable formulation. It's given intravenously, which means it can be injected directly into an IV into your bloodstream, or subcutaneously. So there is no oral formulation of heparin. You'll notice also heparin, it doesn't come in milligrams, it's dosed in units. In the past, about 20 years ago, one of the most common causes of accidental death or even what they considered a significant error of causing prolonged patient stay in a hospital was that the wrong dose of heparin would be given. These were all available in 10 milliliter multiple dose vials, and they all had nearly identical labels. So it was common a nurse might accidentally pick up the 5,000 unit per milliliter instead of the 500 and end up giving somebody 10 times the dose of heparin. This is a blood thinner. What happens whenever your blood's too thin? Well, you can bleed to death or bleed to death internally. So low dose heparin is used prophylactically to prevent deep vein thrombosis and pulmonary embolism. There's something called a heparin flush. A heparin flush is going to be the lower strength heparin, and it's usually 1 or 2 milliliters. Every time they change an IV, whenever they put a new IV bag in, they're going to flush the line just to make sure that they're not introducing just even a speck or a particle that's going to become that the platelets will adhere to and then form a thrombus. What's the antidote? So what happens? Now the labels on heparin, they're color coded, and so one of them is green, one's purple, one's a bright pink, and so you can just tell from across the room which strength of heparin is in the vial. So that was one of the most important steps towards preventing this from continuing to happen. If somebody does accidentally get too much heparin, there's an antidote. It's protamine sulfate, and you use 1 milligram per 100 units of heparin. So there's actually a test question on your final, and I believe it's like somebody gets 2,500 units heparin, that's 2,500 units more than they were supposed to. So what would be the appropriate dose of protamine? Well, you need 1 milligram for every 100 units, protamine sulfate. You'll also see protamine zinc. So just depending on the hospital, but most of them now contain carry the protamine sulfate. Low molecular weight heparins. So then we have something. So we had just heparin. So I was a pharmacist for a good 15 years, and all we had was heparin. But then with science, with technology and advances, they came out with low molecular weight heparins, and there's significant advantages. In particular, with the low weight molecular heparins, they have them in pre-filled syringes where a patient can take them home from the hospital and self-administer, but they're derived from heparin. And by the way, heparin is actually it's a substance that's normally made by the human body. We have fragmin, and if you'll notice, like heparin has PARIN in it, fragmin has its deltapirin. It's dosed in units. It's used to prevent thromboembolism. Lovenox, this is the one you'll probably see the most often if you work in a community pharmacy, and you'll certainly see it in a hospital, and it's enoxaparin. It comes in preloaded syringes. Usually people give themselves an injection 3 times a week, like Monday, Wednesday, Friday. It's used to treat deep vein thrombosis with or without a pulmonary embolism. It's always used after a surgery. So if somebody's had surgery when they're discharged home, as opposed to what previously they would have to stay in the hospital for a week where they're being administered the heparin and the coagulation factors are being monitored. Now they can be discharged home with the Lovenox syringes. They just give themselves an injection once every other day, and it's to help prevent thrombosis formation. Side effect, the main one's hemorrhage. What's a hemorrhage? Hemorrhage is whenever you have bleeding that will not stop. And then thrombocytopenia. The word enia, that means in the blood. Cyto means a cell. Thrombo, that's referring to the like a thrombosis, but it's a type of anemia. It's malformed red blood cells. Now, warfarin, this is one you've got to know. You can start, you can highlight it, you can put asterisk, but Coumadin, you've got to know. Coumadin, the generic name is warfarin. So you think about when you go to war, you're serious. This is poisonous, this is rat poison. It's an extremely important medicine, and it's a very commonly prescribed medicine. After anyone's had a heart attack or a stroke, they're going to be taking Coumadin the rest of their life. Vitamin K antagonist. So don't get vitamin K. So vitamin K is a vitamin, not potassium. Potassium is K plus. So sometimes there's trick questions about like the antidote for Coumadin is potassium. Don't let that confuse you. It's vitamin K. And the way Coumadin works, it actually interferes with, there's a pathway for the blood clotting system, and vitamin K is an essential element in that. So warfarin's taken to prevent future clots. It's not going to do anything about an existing clot. With Coumadin, you're going to always double check the dose. So if you're typing a prescription, you make sure if it's 2 milligram, that it's 2 milligram. If it's 2.5, it's 2.5. But you want to make sure you never guess if there's anything that's not crystal clear, you get the clear information. Also with Coumadin, it can have unusual dosing. Like it's very common for a patient to have to take 1 tablet on Monday, Wednesday, Friday, 2 tablets on Tuesday, Thursday, Saturday, and skip Sunday. But for the most part, people will just take 1 tablet every day. With Coumadin, you monitor prothrombin time and the INR, which is an international ratio, and that just standardizes prothrombin with what's considered a standard score. What interacts with Coumadin? Green leafy vegetables. Why? Because they're rich in vitamin K. Think of what's rich in vitamin K, kale, K-A-L-E. It starts with a K, it's easy to remember. The reason they interfere is because Coumadin works by interfering and disrupting the vitamin K part of the process of blood coagulation. If somebody's supplementing additional vitamin K, well, you don't have enough Coumadin to be prepared for that, and so then all of a sudden, your Coumadin is not going to be as effective. Excessive alcohol ingestion, aspirin. So you're going to find if somebody takes Coumadin, they should not be taking aspirin. There's one exception. Anybody who's had a stroke or a heart attack, or after a certain age, everybody should take at least 1 baby aspirin a day. A baby aspirin is 81 milligram. So 81 milligram of aspirin, and it's taken every day consistently, is perfectly fine with Coumadin. But beyond that, no, you never, ever. So that would be considered an interaction. So Coumadin and 1 baby aspirin, that's fine. Otherwise, no. Ginkgo biloba, that's an herbal supplement that's used to help improve memory. It can counteract, it has an anticoagulant effect, and so it kind of undermines the effectiveness of Coumadin. The antidote for Coumadin. So we already realized that like green leafy vegetables, they keep it from working as well because they're rich in vitamin K. Well, the antidote, if somebody happens to get too much Coumadin in their blood, it's vitamin K. Vitamin K on prescription is called mafetin. It comes as a tablet, but for the most part, you're going to see aqua mafetin, which is an injection. You want the injection because you can control exactly how much vitamin K you're given, and you can give it in proportion to whatever the Coumadin overdose is. So you can see right here, this didn't come out very well, but the tablets are specifically color-coded so that you see a tablet, you know the strength. Even the generics, they follow the same color coding pattern. Why? Because this is such an important medicine. If a patient is expecting a purple pill and they get a white pill, they should have been counseled immediately. Don't take it. Call the pharmacist, just double check. But these are color coded so that you specifically know. And you'll notice they come 1, 2, 2.5, 3, 4, 5. Now they're scored so you can break a 5 in half. The problem is when you break a scored tablet, it's never going to break perfectly in half. So you're not going to get 2 2.5s if you break it in half. It's not going to just come out to be 50-50. Because this medicine is so critical to have the exact dose, that's why they came out with the 2.5 milligram dose. Antiplatelets. So platelets interfere with chemical reactions. How do we prevent platelet aggregation? You want to interfere with the chemical reactions that cause platelets to stick. And once they stick, they aggregate. So aggregate, whenever you have a few start sticking together, it's like that snowball rolling downhill. Aspirin. Aspirin, it irreversibly inhibits cyclooxygenase. It's approved. So people take aspirin, just 1 baby aspirin a day to prevent a TIA, is a transient ischemic attack, or a type of stroke. Aspirin, it's used to help prevent another heart attack. It's used to prevent coagulation. So what are the risks or the problems with aspirin? You never take aspirin. Children under 18, aspirin's avoided, even the baby aspirin, just because there's an association. If a child has a virus and takes aspirin, they can develop Rice syndrome. Rice syndrome is poorly understood, but what happens is the organ systems in the body shut down 1 organ at a time. If it's not caught in time, it leads to death. They do not understand the association or what's magic about, like the minute somebody's 18 or older, there's no association, but it's children under 18. If they take aspirin when they have a virus, there's a 90% chance of developing Reye's syndrome. So you do not give aspirin to a child under 18. Then we have two other drugs. The most common is Plavix, clopidogrel, and it helps prevent recurrence of atherosclerotic events. What that is, atherosclerosis is hardening of the arteries. That's when you have cholesterol that builds up, thickens the walls of your arteries. And periodically, a tiny fragment or piece or shard of the cholesterol will come off. When it does, then you're going to have platelets adhere to it, and then it's going to turn to a thrombus. So Plavix, it makes red blood cells, it makes the platelets slippery, it prevents anything from sticking should any of the atherosclerotic tissue be released. It just like heparin can cause thrombocytopenia and neutropenia. Neutropenia is with white blood cells and thrombos with red blood cells. And then we have Pletol, which is cilostazol. Main thing is you can't use it if a patient has heart failure. The ones that you need to remember is a baby aspirin with aspirin, never in a child under 18, and then clopidogrel. That's the most common one dispensed in community and hospital pharmacy. Then here's three more. Brilinta, you'll see they've been blasting it all over television. Very, very expensive. It's just like when they come out with a new medicine that's like a Me Too medicine. It doesn't really do anything better or more so than the Plavix, but this drug company, they want a piece of the pie. So they're just inundating the television, the advertisements with their product so that patients will come to the doctor and say, oh, I saw an ad for Brilinta, I'd like to try that. And doctors are often willing to let the patient try. We have Effient and ticlopidine. And ticlopidine, it's inexpensive and it's effective, just like Plavix. But like I mentioned, the Plavix or clopidogrel is the one you're going to see most common. That and then a simple baby aspirin. Baby aspirin is just the cheapest one a day. Then we have, if you'll notice, the drugs that end in MAB, that stands for monoclonal antibody. And that just means they've taken some kind of molecule that's normally made in a human body, they've been able to reproduce it in a lab. We have integralin and we have aggrastat. You're not going to be seeing these, like you're not going to be expected to remember these. This only if you're working in a hospital or an acute care setting where there does a lot of emergency surgeries, you'd be seeing these drugs just continuously. Otherwise, you're not going to be working with them. Fibrinolytics. So what do you notice about these? They all end in place. P-L-A-S-E. Place. So what's a fibrinolytic? Once you have a clot that's formed, that clot, it's not a simple matter of just opening somebody up and going in with a scalpel and suction and pulling the clot out. When you've got a clot inside circulation, you have to somehow disintegrate that clot without making things worse. Because when you break up a clot and it breaks up into tinier clots, that means you have multiple more tiny clots that can become big clots. So you need something that's going to break up the clot as well as something that's going to help prevent it from becoming a bigger clot whenever you break it into parts. Fibrinolytics, they bust it up. What's most important about the fibrinolytics is the timing. So if somebody comes into the hospital and they have a blood clot, in particular, I mentioned the example of the young women. It's very uncommon for a healthy young woman to show up in an emergency room and be talking about a severe pain without any kind of explanation, no injury, no fall, nothing else seems to make sense, but there's this power, this strong pain, they can point right to it. And you take their history, they smoke, they take birth control, they just recently took a trip and flew in a plane. The doctors, before they do diagnostic tests, they will put them on a fibrinolytic right away. The sooner you get started, the much better the outcome. Now, the only problem is because when you part these clots, you're predisposed to having somebody end up with bleeding that won't stop, and that's a hemorrhage. So once again, time's critical. A stroke. A stroke is what happens whenever oxygen is applied to a part of the brain when you have interrupted oxygen supply. So the brain needs oxygen, and something that's unique about the body has this mechanism wherever, if you're in a situation where there's limited oxygen supply, well, the brain has the ability to limit how much oxygen is being used by all the organs in the body in order to maximize the amount of oxygen that's accessible or available to the brain. Transient ischemic attack. This is a very common stroke, especially in elderly women over 65. A lot of times a woman will have a transient ischemic attack and never even realize it. It might be an example of she was in the middle of doing something, all of a sudden she pauses and she can't remember what she was doing, and then she gets back to normal and doesn't give it another thought, but it was just transient. Transient means it's something that happened and is passing. Ischemia, that's whenever you have closed off access. So there's no oxygen being supplied. It's a temporary change during a brief period of time. A symptom of a stroke, you have sudden numbness or weakness of the face, arm, or leg. There can be confusion, difficult speaking, understanding their speech, sudden trouble seeing in one eye or out of both eyes, a sudden dizziness, balance, of coordination, or a sudden severe headache without any kind of potential cause. Risk factors for a stroke. What's modifiable? These are the factors we have control over. So cigarette smoking, and this includes vaping, coronary artery disease. And these are affected because we can affect our diet. We can take cholesterol medicines, our exercise level. Diabetes. So 1 out of 3 Americans is pre-diabetic, meaning they'll be diabetic in 5 years. This has to do with our diet. It has to do with our lack of activity. We're sedentary. And it has to do with our weight. Excessive alcohol intake. Hyperlipidemia, that's just high cholesterol. And that high cholesterol leads to atherosclerosis. Atherosclerosis is thickened, hardened arteries. You have less volume of circulating blood, less oxygen being supplied. Hypertension, that's just your heart's pumping hard and you got high blood pressure. Obesity and physical inactivity. The things you can't modify, your age. So as you get older, you're more predisposed. Your gender, women are more likely than men to have a stroke. Genetics, if you have a family history, a parent or a grandparent that had a stroke, chances are higher that you'll have a stroke. Once you have one stroke, you're at a greater chance or potential of having a second stroke, and then race. How do you manage a stroke? First, it's the antiplatelet agents. Why is this? Because the platelets, that's where it starts. Those little platelets, they stick to the tiniest molecules, and then it's like that snowball rolling downhill. So by taking an antiplatelet, you prevent an initial episode in the patients that are at high risk. Once somebody's had a stroke, they're going to take an antiplatelet because they're at higher risk for having another stroke. Anticoagulants, they prevent your existing clots from getting worse or expanding. Fibrinolytic agents, so they're going to dissolve thrombus or thrombi that are already existing. And then there's one drug called Agranox. It's dipyridamole with aspirin. And that's if somebody's had recurrent strokes or transient ischemic attacks. So some people, especially it's elderly women, usually over 75, and they'll have frequent TIA, but they discovered just with the baby aspirin a day, or in particular aspirin with dipyridamole, that'll prevent the TIA. So now let's wrap it up with cholesterol. Hypercholesterolemia. Emia means in the blood, cholesterol is what it is, and hyper means high. So that just means you have a high amount of cholesterol in your bloodstream. Hyperlipidemia. So that means the levels of one or more of the lipoproteins are elevated. So when we talk about cholesterol, we've got triglycerides, we have low density, very low density, high density lipoproteins. And so it's just an abnormal, like when you have too low of the high density, too high of the low density, and high triglycerides. When you just kind of have a mixed group of cholesterol issues, it's hyperlipidemia. This lipidemia, that's atherogenic lipoproteins are elevated, and the levels of the anti-atherogenic lipoproteins are disproportionately decreased. What causes dyslipidemia? So it can be inherited, it's genetic. If you eat a diet that's high in saturated fat. Lipoproteins, we have high density lipoproteins, HDL. HDL transports cholesterol back to the liver for excretion. This is the good cholesterol. So this is an example where getting high is good. High, you want the high HDL. So I'll tell you guys to get high. Low density lipoproteins. They bring cholesterol to the body's cells. This is the cholesterol that gets deposited in arteries that leads to arteriosclerosis. It's the bad cholesterol. Then triglycerides. They're fats. They're neutral fats that are made from carbohydrates. So carbohydrates are sugars or pastry or breads, and they're converted into fat to be stored in fat cells. So how do we manage cholesterol? The statins. The statins are a big deal. So most insurance companies, because statins, we do know this, if somebody has high cholesterol, they're going to end up with atherosclerosis, and it's just a downhill effect. Atherosclerosis, high blood pressure, you're going to end up with congestive heart failure, you're going to end up with strokes, just one problem after another. The statins, they interfere, they're HMG-CoA reductase inhibitors. And so HMG-CoA reductase is essential for converting or making cholesterol. The inhibitors, that means that they're going to inhibit the production of cholesterol. How you recognize the HMG-CoA reductase inhibitor? They end in statin. So you got atorvastatin, fluvastatin, lovastatin, pitavastatin, rosuvastatin, simvastatin. So guys, this took me a minute to make this slide. I know this information. I didn't make this for myself. I made this for you. I made it because like when you're making your drug cards, if you made a drug card with a statin, let's say you did atorvastatin, it's the #1 statin drug that's being dispensed. You don't even have to remember the HMG-CoA. You just need to remember it's used to lower your cholesterol. Then, what are the side effects? Most common side effects, if you look in your drug information handbook, it's going to have nausea, vomiting, diarrhea, rash, just all kinds of things. But all we care about, the most common, an upset digestive system, and that usually is just transient when you first start taking it. A headache, that's usually when somebody first starts taking it, if it's experienced at all. Rhabdomyolysis, now this is a black box warning. Rhabdomyolysis, this is whenever you have myo, means muscle tissue, lysis is breakdown. You're having breakdown of healthy muscle tissue. And when it breaks down into components that are very harsh on the body, that are detrimental. This is a condition that this means that it's experienced by muscle pain or cramping. Now, it's severe. I used to wonder, how did somebody understand or know if, because everybody has muscle cramps and pain, but rhabdomyolysis, it's extreme. I was placed on rosuvastatin, and within about a week, when I was just trying to dial a telephone number, my finger muscles, the muscles in my fingers literally hurt. And so we realized I experienced rhabdomyolysis. We stopped the drug, and within about 4 days, I was perfectly normal. So I experienced it, and it only happens in about 1 in 800 people have the rhabdomyolysis. If they do, though, it's got to be discontinued immediately. Now, who shouldn't take statins? Statins, because they act in the liver, because that's where they do all their work. They're metabolized by the liver. They're a burden on the liver. You've got to be careful if anybody's got a liver disease like hepatitis, a chronic liver condition, or somebody's an alcoholic. Alcohol significantly overburdens the liver. It causes cirrhosis. So if somebody's an alcoholic, this statin would be an extra burden. You wouldn't be metabolizing it correctly. When you have elevated doses of the statin, that increases your likelihood of rhabdomyolysis. Myopathies, just the muscle tissue damage, liver function abnormalities. There's, and especially in diabetics, there's an association where it slightly elevates your blood glucose, and that really has to do with displacing the carbohydrates that are made into triglycerides. And then if somebody has kidney dysfunction, you have to do a dosage adjustment. So for statins, and there's going to be one other thing I'm going to point out, but statins, if they end in statin, they lower cholesterol. You're going to find out they raise your HDL. So that's good. You want to get high. They raise the high cholesterol. They lower the LDL. And then they do lower triglycerides, just not as well as some other medications. Now, grapefruit juice. Because these are metabolized, they're metabolized by CYP430 enzyme. And grapefruit juice inhibits this enzyme. So if somebody drinks grapefruit juice and takes a statin drug, it's going to significantly elevate the blood level and slow down the excretion of the statin. When you do that, all of a sudden you start increasing potential for side effects, especially rhabdomyolysis. So if somebody takes a statin and they love grapefruit juice, well, they can drink grapefruit juice. They just need to drink it an hour before or 2 hours after taking the statin. Now, something else that's interesting, statins, they're usually taken once daily at bedtime. The reason they're taken at bedtime is it has to do with the circadian rhythm of the earth, but our bodies make most of our cholesterol during the night. So if you're a night shift worker and you sleep during the day, that doesn't change anything. It's the night hours. So it's between about 10 p.m. and 4 a.m. Your body makes most of the cholesterol. And for that reason, most doctors will say take one tablet or one capsule a day at bedtime. And the other thing is most people aren't going to be drinking a glass of juice at bedtime, so that also minimizes the chance. But if a patient loves grapefruit juice or eats grapefruits, it's got to be an hour before, 2 hours after. So just right there, we covered the information that needs to go on a drug card. If you do it for one drug card, guess what? There's 6 right there, and you know this information. So if you see any drug and it ends in statin, you know rhabdomyolysis, you know liver, alcoholism, you don't use. You know grapefruit juice is an interaction. You know how it's taken once daily. Folic acid derivatives or fibric acid, fibrin. What's the FIBR? So when we talk about suffixes, prefixes, or root words, we're looking for a part of the drug name, the generic name, that will identify the drug for you. So once you memorize fibric acid, FIBR, and FIBR, that's what you look for. If you look at the generic name, fenofibrate, FIBR, you got fenofibric acid, you got gemfibrozil. So if you couldn't remember the brand names, but you just saw the generic name, you'd remember fibric acid derivative. How do they work? They increase your excretion of cholesterol in the bile. And so what are some of the side effects? Well, the main side effect is gas, the digestive system, diarrhea, nausea, vomiting. And then if somebody has gallbladder problems, because the gallbladder is where you're making your bile, then you have to use caution. Bile acid sequestrants. What this does, these bind, they block cholesterol absorption because they bind with and prevent the absorption of cholesterol into the body. So cholestyramine equestrian, it originally came out as a powder that you mixed with water or juice and you drink a cup twice a day. Then they came out with a chewable bar, kind of like a nutrition bar, but they just didn't taste good. It never really took off. Where you're going to see equestrian used mostly is in compounding because this binds with bile. Bile is acidic, it burns. So when a baby has a diaper rash or diarrhea, whenever that diarrhea, it's extremely irritating, almost like acid against the baby's very tender skin. So we make a powder by adding equestrian into Aquaphor, and you apply that just like a rash cream around the butt whenever you're changing your diapers or when a baby has the diarrhea. So whenever they do have any diarrhea, any of that bile acid that's coming out, it gets bound into the equestrian and does not affect the skin. So equestrian now, most pharmacies, you'll see a can of it in the compounding section. They mix the powder with Aquaphor and make a diaper rash ointment. Now where you'll see that the 2 most commonly prescribed is Welchol and Colestid. Welchol is the most common. So what it does, again, it binds with bile acid to decrease its absorption. The most common side effects, they're GI, and with Welchol, it's constipation. And so if somebody's triglycerides are over 300, you have to be very careful because if you're using too much of this, you're going to be preventing them from absorbing their fat-soluble vitamins. Now, these are just some miscellaneous items. Ezetimibe, sounds like a country in Africa. Zetia, it inhibits the absorption of cholesterol in the small intestine. And so it's extremely effective. When it came out, it just never really took off. Where you're going to see it mostly, it's in combinations like Vytorin. They'll combine it with a statin drug. But ezetimibe, it inhibits the absorption in the intestines. Then these are over the counter. Well, vitamin B. The niacin you're going to find is vitamin B3. Niacin, it inhibits the VLDL. So VLDL is converted to LDL. So if you inhibit VLDL synthesis, you're going to lower your triglycerides and your LDL. The only thing with niacin has an unusual side effect. When you take the dose of it, it causes your face to turn red. So any of y'all have noticed my face is red. Some days I take niacin. Now, it can be minimized when you take it with aspirin, but you still, for the most part, you're going to get red face. It can increase uric acid, and whenever we have renal, we'll discover when we talk about gout's whenever you don't excrete your uric acid well. Gout can result, it usually shows up first as a severe pain in the toes, but you don't want uric acid to build up. So you have to be mindful. It's an example of a vitamin you just don't want to take too much. And then nausea, vomiting, and diarrhea. It can increase blood glucose levels, but that's really kind of insignificant. Niaspan is niacin. So niacin you can buy over the counter. It's just a B vitamin. Niacin, it's the same thing, but a drug company, they made it into a sustained delivery. It's a capsule with little BB sustained release pellets. So it inhibits the VLDL in the liver. There's less flushing, and it really has to do with just because it's releasing a lower amount of the niacin over the 12 hours. And then last is psyllium. If y'all remember psyllium is Metamucil or Fibrol. And for those of y'all that were there when we finally did it and it worked, if you mix psyllium and just water, you put food coloring in it, you put it in the microwave, you'll notice it'll turn into a solid. It's just almost like plexiglass. Psyllium, what's amazing, it absorbs the it has the very same effect as a fiber diet. And so what's interesting about psyllium, they use it for both. If somebody's constantly dealing with constipation, they'll use the psyllium, and it works just like fiber, and to help have a normal stool, a bulky stool that's soft and passes. Also, if somebody has a problem with continuous diarrhea, well, the psyllium, it works just like fiber. It absorbs that excess water, and so it's used to treat diarrhea as well. Omega-3 fatty acids, these are fish oils. We have Leveza and Vasipa, they're derived from fish. This is an adjunct to your diet. So to lower your triglycerides, the first thing is your carbohydrates. And the second, though, is the omega-3 fatty acids. So you can buy this over the counter, the fish oils. The biggest problem, and even with Leveza and Vasipa, is after you take it, a lot of people, they say they just kind of have a fishy taste after they belch or burp or just in their mouth. Then there's combinations. That's where, like amlodipine. What's amlodipine? Dipine, that's a calcium channel blocker. Atorvastatin, statin, that's for what? Cholesterol. So you've got a calcium channel blocker and a drug for cholesterol because they go hand in hand in helping prevent cardiovascular disease. Niacin and lovastatin. The lovastatin, it raises HDL, lowers LDL, and it has a beneficial effect on triglycerides. Niacin, which is available over the counter, it's probably one of the strongest things we have to lower triglycerides. So they just combine the two. This is another example of where a drug company. So first we had lovastatin. Then whenever they lost their patent, they add lovastatin plus this drug that's already available inexpensively, and then come out with Advocor. Same thing, simvastatin and Zocor. Zocor lost their patent. They just combined it with niacin and came out with Simcor. What's complementary alternative medications? These are herbs, supplements, vitamins that are used, and you're going to find, especially in other countries, some of these are used instead of the drugs we use here. You're going to find sometimes these drugs are as effective, if not more effective. So you have plant sterol esters. They significantly lower the LDL, and remember, you want to lower the low, and you want the high HDL. You want to raise HDL, lower LDL. Adjunct means it's just something you use in addition to your diet, and drug therapy for hyperlipidemia. Hyperlipidemia just is referring to your LDL, HDL, and triglycerides. Then there's beta-sitosterol. It's found in margarine and juices. Red yeast rice, It's fermented rice product that's used in recipes and medications to lower cholesterol and improve your cardiovascular health. It contains monocotyledons, which are agents that have the HMG-CoA reductase inhibitor activity. As a matter of fact, it was from red yeast rice that they did studies of the molecular structure to modify and create these statin drugs. Alpha tocopherol, which is vitamin E. Vitamin E, an antioxidant used for cardiovascular disease, cancer, diabetic neuropathy, and the effectiveness, though, is not proven. But antioxidant, that's just what it's doing, is it's helping to enable your heart to function using less oxygen. And then finally, garlic, its effectiveness in treating atherosclerosis, so it's effective to help prevent hardening of the arteries for blood pressure. Some people say it works for cancer, skin, fungal infections, plus it keeps away the vampires. It must contain allicin, the active ingredient. That's actually what gives it its very strong odor. And then there's drug interactions with warfarin and protease inhibitors. Protease inhibitors, these are drugs that are used for an antiviral for HIV. And the medicines for HIV, they have such severe side effects. You've got to be extremely cautious of anything that has an interaction. Remember warfarin. Warfarin, you've got to be very careful. Just a tiny modification, slight dose adjustment, you're going to end up either with a drug that's going to cause too much coagulation and you'll end up with blood clots, or you're going to end up with not sufficient and you can hemorrhage or you can have internal bleeding. So the summary, angina pectoris. So angina just means you're not getting enough oxygen to your heart. Pectoris, so you're thinking of your pectoral muscle, it's in your chest. So angina, but angina, not enough oxygen to the heart. The drugs used to treat angina, they're beta blockers, nitrates, calcium channel blockers, and a metabolic modifier. And that one's very last resort, and it's only in the hospital. The normal heart rhythm is generated by the sinoatrial node. Remember, that's going to be in your file. And the normal heart rate's 80 beats per minute. The classes of drugs used to treat arrhythmias. So they've defined the type of arrhythmia. And if you ever look at an EKG and it looks like little mountain peaks and it's hard to understand what it means, but that's where they determine the different classes and which agents used where to treat the arrhythmia. Heart failure occurs when the pumping ability of the heart can no longer sustain the blood flow that's needed by the body. So for example, one example is just when somebody becomes obese, all of a sudden you have a much larger body mass and you just got the same heart, but it's having to pump this blood around through greater obstacles. And plus, as you get older, you have hardened arteries, you have compromised circulation. So the heart's having to work harder just to try to do the same job. So you end up with heart failure whenever you're not getting the adequate blood circulation throughout the body. Medications used to treat heart failure include vasodilators, ACE inhibitors, and then there's human B-type natriuretic peptide. One of the most important drugs in heart failure, though, is carvedilol. It's a beta blocker. Drugs commonly used for hypertension, ACE inhibitors, ARB, so it's the angiotensin receptor blockers. Antagonist and blocker. Blocker is just another word for an antagonist. Antagonist means that blocks a receptor from being able to be stimulated. And so it's just the ARB, angiotensin receptor blocker. Beta blockers, and again, most specifically, and I had an arrow on that one side, it's beta 1. It's beta 1 in the heart. When you stimulate beta 1, it's going to make the heart speed up. If you block beta 1, it's going to slow down the heart. So beta blockers help slow down the heart when the heart's going too fast. Calcium channel blockers and diuretics. And diuretics, they work by eliminating the extra fluid that's in the body. And with that, having less fluid in your bloodstream, it creates less of a burden on your heart to circulate the blood that's in your system. MI stands for myocardial infarction. That's whenever there's prolonged decrease in oxygen delivery to a region of the cardiac muscle. So your cardiac muscle, oxygen is essential. Just like we are human beings, we need oxygen to live. So do the cells in our body, our muscle tissue. And whenever you're not getting adequate circulation of oxygenated blood. And one example, if somebody has COPD or emphysema, if you look at a lung scan or an autopsy of somebody who's smoked for years, or even people that were coal miners, people that work in areas where they had damage to their lungs. The lungs are just completely coated with a black tarry substance. So then you only have a very limited surface area of the lungs for oxygen and carbon dioxide to be leaving and gaining, coming into and leaving the body. Whenever you have limited oxygen coming in, then there's only so much oxygen available to the heart and to circulate throughout the body. Then when there's a compromise of this, it starts with angina. Angina is whenever you're not getting enough oxygen to the heart, but once it reaches a certain point, then it leads to myocardial infarction. Myocardial infarction leads to ischemia and necrosis, or death of the cell tissue. Beta blockers and low-dose aspirin are prescribed to reduce the risk of death and recurrence following a myocardial infarction. Blood clots in the bloodstream can cause life-threatening pulmonary embolism and other serious damage. Anticoagulants, antiplatelets, glycoproteins, and fibrinolytic agents are used to manage blood clots. A stroke can be caused by cerebral hemorrhage. So that's whenever you have a blood vessel that bursts. It can be a teeny, tiny blood vessel in the brain, or cerebral infarction, just like a myocardial infarction. This is just if there's a part of the brain that's not getting enough oxygen, it leads to an infarction, which leads to the necrosis or ischemia or death. Antiplatelets and anticoagulants are used to manage stroke. The liver makes triglycerides and cholesterol and carries proteins such as lipoproteins which circulate the blood. Again, which one's the good one? High, HDL, high lipoprotein, HDL. And the one that we don't like is LDL. LDL carries the cholesterol around the body and deposits it throughout the body, whereas HDL carries cholesterol back to the liver to be eliminated. Drugs are used as an adjunct to diet to treat dyslipidemia. So whenever your triglycerides, remember, they're most directly associated with your carbohydrate intake. So we've got triglycerides and the cholesterol, HDL, LDL. Whenever those three are kind of off balance, it's dyslipidemia. Drugs can only help so much. We've really got to get level of activity, exercise, and diet under control. So that was it, guys. You have a great afternoon. I hope that you'll watch this. I hope that you'll use this in creating your drug cards. The drug cards, they're not just an activity to keep you busy. They're an activity to help you memorize and learn your drugs. I want you to memorize them. When you memorize one, when you spend the time you spend making one card has profound benefit. With the time you spend creating the drug, the ACE inhibitor, if you do lisinopril, all of a sudden you're able to apply so much of that to all the ACE inhibitors. When you see a drug that ends in pril, you know it's an ACE inhibitor. Same thing with statin. You saw all the statin drugs. Once you do a drug statin, you know rhabdomyolysis. That's the muscle deterioration is a black box warning you have to discontinue. You remember statins, they're tough on the liver. If somebody's alcoholic or has a chronic liver condition, they can't use them. You know that statins, you take one a bedtime, usually one a day at bedtime. We do that because most cholesterol is made at night. What food or drink interacts with statins? Grapefruit juice. What about Coumadin? Coumadin, what's it used for? It's a blood thinner. Why do we use a blood thinner? Well, after somebody has a stroke or a heart attack, and it's to help prevent thrombus formation so that you don't have another stroke or heart attack. And then with Coumadin, we monitor the PT, the prothrombin time, or the INR. And then what's the difference between heparin and Coumadin? Well, heparin, it's only IV or subcutaneous. It's injectable. It's dosed in units. What's an antidote for heparin? Protamine sulfate. How do you dose the protamine sulfate? It's 1 milligram for every 100 units of heparin that somebody's been given too much. So remember, heparin's dosed in units. With Coumadin, can you take aspirin with Coumadin? Well, Coumadin, there's a significant interaction and life-threatening dangers. You can bleed to death. However, you can take 1 baby aspirin a day with the Coumadin. Coumadin comes dosed, and you saw the different strengths and the different color coding for the tablets. Also, the dosing of Coumadin. You always want to make sure if there's any confusion, you clarify it. You never guess, because most patients just take 1 tablet a day, but other patients will take 1 tablet on Monday, Wednesday, Friday, and then 1.5 tablet on Tuesday, Wednesday, Thursday, and 2 tablets on Sunday. There's just different schedules for the Coumadin. So anyhow, I do hope this is helping to shed some light. You can watch these, go through these, freeze frame, rewind, or just use the PowerPoint slides. But use these when you're creating your cards. When you're creating your drug cards, don't go directly to the drug card. Start out with a separate sheet of paper. Identify what's the brand, what's the generic, what's the drug class. Read about the drug class. Read about it in your certification exam review book. Read about it in your pharmacology book. You're going to find very simple, reduced paragraphs, and you're going to be able to write down summary information, brief bullet points, and it's going to apply to the drugs in that class. Then once you get that information, then you can fill out your card. And when you're filling out your card, I want you just to be mindful of how much of this applies to all the same drugs in this same class. Then all of a sudden you're going to realize, holy cow, I spent all this time, but now if I see a ACE inhibitor, I'm going to know exactly. Finally, I'm going to end with this, with the nitrostats. So why is nitrostat dispensed in the amber glass bottle with a 10-screw cap? Is it because nitroglycerin explodes if you put it in plastic? No. It's because it's so sensitive to light. The amber glass protects it from sunlight. The 10-screw cap, that helps make a seal to prevent moisture and oxygen, because the tablets are friable. They're very fragile. With the nitrostat, it's not dispensed in a childproof container, and that's because if you're having a heart attack, you might not be able to open a childproof lid. Once somebody opens a bottle of nitrostat, even if they just use one tablet, that bottle needs to be replaced in 30 days. Just being opened once, the oxygen and moisture that gets introduced into the bottle is going to deteriorate and break down the effectiveness of the active ingredients in the nitrostat. Finally, what is the life-threatening drug interaction with the nitrates? So anybody that's taking a nitrate, we've got nitrostat, nitrobid, nitrodur. You've got isosorbide dinitrate, isosorbide mononitrate. The drugs that have a life-threatening interaction, they're the EDD, erectile dysfunction drugs. They end in AFIL. One student gave a presentation and she says she remembers the EDD drugs because they end in a fill. Just like when she sees her boyfriend, she wants to cop a fill. It's crude, but it helps some students remember a fill, AFIL, erectile dysfunction drugs like Viagra or Cialis or Levitra. Because nitrates cause vasodilation, they open up your vessels, allowing more blood flow. And then the EDD drugs, they do the same thing. They cause an extreme vasodilation to allow blood to engorge the penis to make the erection. But if somebody's on a nitrate and they use an EDD drug, all of a sudden you just overwhelm the dilation, and it can lead to a life-threatening orthostatic hypotension to such a plummet in blood pressure. People usually, they lose consciousness, fall to the ground, and it can result in death. There's been several hundred people die from it. That one, because it's when you have a drug, there's not a whole lot of drugs that have an interaction where you die if somebody doesn't warn you. So when there is a drug that you take, and if you take it with something else, it can cause death, it's something you need to know as a technician. Nitrates and the EDD drugs, life-threatening. So you need to know that. You need to know warfarin. You need to know ginkgo biloba and garlic. They interact, aspirin. But then most importantly with warfarin, it's what food? It's foods that are rich in vitamin K. Which foods are rich in vitamin K? The green leafy vegetables. And a perfect example is kale. Okay, I'll end with that. Have a great afternoon, guys.